Welcome and thank you for joining us this morning for Issues and Views, Buffalo, New York's weekly public affairs program focusing on topics and concerns that affect you and your community. We hope the information you hear today is beneficial to you. Now here's your Issues and Views host, Todd Anderson.
Good morning and welcome to Issues and Views. I'm your host, Todd Anderson. This morning we're going to talk about prostate cancer, and we'll focus on early detection and screening with Dr. James Moeller. He's here as the chair in the Department of Urology and also Associate Director and Senior Vice President for Transitional Research. Also a prostate cancer survivor. Richard Satterwhite is here with us today, and he's also the president of Men Allied for the Need to Understand Prostate Cancer, and the organization is called Man Up. And we're going to begin by speaking with Dr. James Moeller this morning. Dr. Moeller, thanks for joining us on Issues and Views.
Nice to be here. Thank you.
Now, prostate cancer is obviously a disease that impacts men. Is this a common type of cancer?
Current estimates are that about 1 out of 6 or 7 men will be told they have prostate cancer during their lifetime. So yes, it is a very common cancer.
That's pretty scary. Well, what do men need to what do men need to start thinking about regarding prostate cancer?
Well, prostate cancer is very controversial because if it's detected early, it's very, very curable. Mm-hmm. If it's detected late, as it used to be decades ago, then it's incurable. So we have a test called the PSA test that was developed by Ming Chu at Roswell Park. And when used properly, it can detect the cancers that you need to detect and treat, and it can avoid overdetection of cancers that men get as they age who don't need to be diagnosed or treated. That's where the controversy comes. So you want to use an early detection test in the people in whom you need to find a potentially fatal prostate cancer so you can treat it and cure it.
So now when you say it could be cured, are you speaking of cured in terms of death?
Yes. Prostate cancer will cause the death of about 4% of men in America. So we want to detect the cancers we need to prevent those deaths, but not over-detect cancer. That prostate cancer is strange because it's very slow growing, and by the time you get to be 100, you have a 100% chance of having prostate cancer.
Wow.
But you're not going to die of it. So we want to distinguish those potentially fatal cancers from those that occur with aging, and that's what makes this such a complicated subject to discuss.
Now, prostate cancer, as opposed to an enlarged prostate, is an enlarged prostate cancer? No.
So all men have gradual enlargement of their prostate as they age, simply because prostate growth is driven by testosterone produced by the testicles. That's a normal part of aging. As you get older, you'll start to get up at night, and that's due from prostate enlargement. Completely different process than cancer. Cancer occurs around the edges of the prostate. It produces no symptoms until it leaves the prostate and gets to your bones or other organs and causes pain. So that's the problem. You don't want to have your cancer diagnosed when it's in your bones because then it's incurable. You also don't want to confuse yourself by mistaking the benign enlargement of the prostate for prostate cancer, but you want to find those prostate cancers that are capable of growing and causing your death so they can be treated.
Now, is there a way to check on your own for prostate cancer?
No, because it does not produce symptoms until it's incurable.
Well, how do you screen for it? Well, outside of this, you said the PSA. Is there another way you screen for it?
Well, the best, if you're going to do one thing, the best thing is to have a PSA. A better thing is to have a PSA and a prostate exam. And a lot of men don't like prostate exams because that requires putting a finger in your rectum to feel the prostate.
Right, exactly. Are there screening guidelines?
There are about 5 different organizations that put out screening guidelines, and this is what confuses men because every one of the guidelines is a little different, and they range from you should not have a PSA test at all because it's not clear that it saves enough lives to warrant the side effects of treatment. That's United States Preventative Task Force. 2, the NCCN and AUA and European guidelines, all of which advocate a PSA every 1 to 2 years for men between 50 and 70, and perhaps sooner in men who are at higher risk for prostate cancer.
Now, are there certain groups of men that are at an increased risk of getting prostate cancer?
Yeah, there's 2 very well-known risk factors for prostate cancer. Some prostate cancers, about 1 in 10, run in families. And so if you have a brother with prostate cancer, you're at higher risk. Mm-hmm. Your risk is also higher, but not as high if your father has had prostate cancer.
Okay.
Then the other big risk factor is if you're African American. So African American men are 1.7 times more likely to get prostate cancer than Caucasian American men. And if they're diagnosed with prostate cancer, they're 2.4 more times likely to die of it. So for unclear reasons, men who are African American have a higher risk of prostate cancer, and the cancer they get is more aggressive.
Is there something you can do to protect yourself?
Castration before puberty is protective, but most people don't want to participate. This is part of being a man, that your prostate is stimulated by testosterone, and it causes it to slowly grow, and it also causes prostate cancer. So the only real preventative for which there's good evidence is more fruits and vegetables and less red meat in the diet. And if you want to get really aggressive, you can go all the way to an Asian diet, very high in soy, because that diet has been shown in many, many studies to prevent but not eliminate your risk of prostate cancer.
So soy.
Soy.
Okay.
A pound of tofu, or you can get genistein in capsules, which for some reason most American men prefer the genistein capsules to the pound of tofu.
Now, does one get screened by their primary care physician, or can they? I know they do that at Roswell, but can your primary care physician do it?
Yeah, any physician can have the discussion about the pros and cons of an early detection strategy. The American Cancer Society, the American Urological Association, and National Comprehensive Cancer Network, NCCN, all put out pamphlets that are very friendly to physicians and patients to explain the controversies about early testing. And I'm a big believer that more information is better than less. And I think that men at higher risk should have a baseline PSA at age 40, a normal risk at age 50, and then every 2 years until you get to about 70, you should have your PSA and prostate checked, because I would rather know that I have prostate cancer when it's curable. But then if it's found, you have to make certain that it is aggressive enough that it warrants treatment.
Okay. So what would you recommend be the first step for someone listening out there who's wondering whether he should be screened?
So I think if you're under 50, you have nothing to worry about unless your brother has prostate cancer or you're African American. Mm-hmm. Then you should have this conversation beginning at age 40.
Okay.
Once you have the conversation and decide you'd like to have prostate examination and PSA, then you should do it at least every 2 years. The best interval is actually 2 years, but many of the guidelines say as often as 1. But I think every 2 years is fine. And if you're absolutely averse to having a prostate exam, PSA is good, but both is better.
Now, are African Americans more at risk because of diet, or what is it? Or we don't know?
That's a very interesting question, because the answer is nobody knows. There are all kinds of theories, and there's lots of people doing very good research on the subject. And what amazes me is there's no clear answer yet, in spite of many, many research projects and thousands of publications on the subject. There's really no clear answer.
And what would you say to a man who's listening right now who's dragging his feet on getting screened?
I always like to refer them to the women in their life. Women have been getting pelvic exams since they were teenagers, and men need to belly up to the bar and have a prostate exam and a PSA, providing they understand the controversies that we talked about over-detection and over-treatment.
Is it really that important?
Well, I think if you have a 1 in 25 chance of dying of prostate cancer as a Caucasian American and as high as a 1 out of 15 as an African American, I think most men would like to do something that might prevent that death. Dying of prostate cancer is not pleasant, and that gets lost in this whole discussion. When PSA was discovered and put into routine practice about 25 years ago, the death rate from prostate cancer has fallen by 40% in America.
That's good.
Yeah. So we have a tool here to address the epidemic of prostate cancer, especially in African American men, and I think it should be used.
Now, I think you said there are no symptoms?
No symptoms at all until it spreads to the bone. None.
Really?
The problem is the cancer develops around the periphery of the prostate.
Mm-hmm.
The benign enlargement of the prostate's in the center, and so that causes you to have obstructive symptoms. You get up at night, your stream becomes weaker, you got to rush to the bathroom.
Mm-hmm.
None of that happens with prostate cancer because it grows around the edge of the prostate. And you don't get any symptoms until it leaves the prostate and gets in your bones and causes pain. Then it's incurable.
So bones meaning, give me an example.
So a man has pain in the lower back and hips. It comes one day, it gets worse every day, it never goes away. That's prostate cancer type pain. Men are very good at saying, there's nothing wrong with me, so they wait a while, and eventually it becomes bad enough, they go to the doctor, and then they're found to have a PSA of 2,000. Bone scans show spread all over their body, and then the only thing they can do is androgen deprivation therapy, commonly known as hormone therapy, or castration, either by medical or surgical means. And that will put the cancer into remission, but that remission is only an average of 3 years. You're not talking about cure. You are going to die of prostate cancer.
Okay. So if it does get to that extent and you have to be castrated, is there anything that can be done for the guy?
So the castration doesn't have to be done surgically. It can be done medically with shots that shut down the testicles.
Oh, okay.
And then there have been 5 new FDA-approved drugs that can also be used once the cancer eventually becomes refractory to the hormonal therapy. Each of these
refractory. What does that mean?
The hormones don't work anymore.
Okay.
So there are different agents that have been approved. There's been 5 of them in the last 7 years. And so men have a bunch of options for additional treatment. But again, these are all just to extend life. They are not going to cure the cancer. The opportunity to be cured is to have your prostate cancer found when it's still all within the prostate, and then to have the prostate either irradiated or removed.
Okay, so if cancer is detected and it's detected early enough such that you're not going to die, are there still situations where you need to be castrated medically?
No.
Okay. Because a lot of men think, I'm not going to be able to have sex anymore.
So the treatments for prostate cancer can be done so that sexual function is preserved. And if it's lost with one of the treatments, then it can be restored. And there are now a whole bunch of different ways to do that. Mm-hmm. And 95% of men who lose their sexual function as a result of treatment can have it restored by different means.
Well, Dr. Muller, what is the actual treatment like, and why do men try to sway away from it?
So there's really 3 types of treatment now. When your cancer's found, when it's highly curable, some men are best served by watching it very carefully for a couple of years and then making a decision about whether treatment's necessary. When you have a very low-risk prostate cancer, which is about 50% of men, the best choice is often watching it carefully, and only about 1 in 4 will ever need treatment. In other words, 3 in 4 can watch their prostate cancer for the rest of their life and not have any side effects of treatment and never risk dying of prostate cancer. If you need to be treated, there's really two treatments. Remove the prostate, which is now done almost always using a surgical robot. And that is a big advance because blood loss is less, hospital stay is usually just overnight, and you recover very fast. In fact, many men can hardly tell they've had an operation. You still have the side effects associated with removal of the prostate.
Which are what?
You can lose your urinary control, but a good surgeon, that should only happen to less than 5% of men, and that's treatable. You can lose your erectile function that we talked about earlier, and that too is treatable. A good surgeon should be able to preserve the erections in more than half of the patients he or she operates on.
So how is it? How is that treatable? What do they do?
Actually, remove the prostate.
No, I mean, how do they restore erectile function?
So erectile function can be restored with medications if you're having erections but not good enough for intercourse. An erection can be caused by using a suppository that's placed into the urethra and causes an erection that you'd have a hard time telling from normal. You could also use a vacuum erection device to induce an erection. You can inject, using a little diabetes needle, medications into the penis to cause an erection. And finally, you can have a penile prosthesis implanted that's a mechanical device that causes an erection. So a lot of these don't sound too exciting. So the best thing to do is to have your operation done well so that you don't need them. But if you do suffer erectile dysfunction afterwards, you can do what I call climbing the ladder of these treatments, from the ones that are the easiest to do to the more difficult.
Or you can just abstain forever, right?
You could do that too. Then the other treatment that we need to mention is, rather than removing the prostate, you can destroy the prostate with radiation. And you can do that either by implanting radioactive seeds or giving external beam radiation. And this treatment perhaps has a slightly lower cure rate over time and also has a completely different side effect profile. The same two things happen, erectile dysfunction and loss of urinary control, but it doesn't happen for 4 or 5 years after the treatment. And by 10 years, 9 out of 10 men will have neither loss of control of the urine or loss of control of stool, but the chance of losing your erections is still considerable, probably 70% after 10 years.
Okay, let's get back to the racial differences in terms of prostate cancer. You said you've done research, or there is research being done?
So we have the largest population-based research study ever conducted of prostate cancer, which means it's not patients that come to a hospital or come to a doctor's office. We went out into 2 areas of North Carolina and Louisiana and interviewed men in their homes, collected fat samples from them, blood, urine, clipped their toenails, did extensive interviews. And 2,300 men participated. And this study enrolled patients from 2002 to 2007. Mm-hmm. And the reason we chose Louisiana and North Carolina is very, very interesting. Mm-hmm. The prostate cancer mortality in the 2 states in Caucasians is identical, but it's very different in the African Americans. Much higher in North Carolina than Louisiana. The diets are different. The environmental exposures are different. And so it's kind of a natural experiment. We've been following these men now for the last 10 years and have published 25 papers. And what's most interesting that I've learned from this study that enrolled an equal number of African Americans and Caucasian Americans is it seems to be the biggest problem is a delay in diagnosis in African Americans, because the quality of their interaction with the American healthcare system is not as good as Caucasian Americans. They're more likely to go to the doctor only when they have something wrong, and they often don't see a doctor or see multiple different healthcare providers. And so the discussion is focused on what's wrong with them, and they don't ever get to preventative health stuff about hypertension and diabetes prevention and early detection of the different cancers.
Well, Dr. Moeller, thanks for that information. Very, very informative. And we have a cancer survivor with us, Richard Satterwhite. Richard is the Also the president of Men Allied for the Need to Understand Prostate Cancer, which is Man Up, and also the Prostate Cancer Navigator at RPCI. And Richard, thanks for joining us at Issues and Views.
Yeah, thanks for having me.
Well, tell me about your cancer story.
Yeah, cancer story. I'm a 9-year survivor. Before prostate cancer, I didn't know what a PSA was. Mm-hmm. And as Dr. Moeller had pointed out, it is part of the exam to test for prostate cancer. When I had symptoms, which I guess I was told were typically associated with an enlarged prostate, and ED issues, erectile dysfunction, and also urinary issues as well, getting up multiple times during the evening. And the first time I heard PSA, I actually said to my doctor, you're going to give me a public service announcement. He explained what PSA meant. It was a blood test and also a digital rectal exam as well. Mm-hmm. And from there, I went on to see a urologist, had a biopsy, and they told me that I found cancer cells in the samples. And I started my journey.
So what was that like when you were told you have cancer? Do you remember that day?
Yeah, it was the absolute worst day of my life. Second to losing my father. It was I had described it as getting hit repeatedly in the gut with a baseball bat. It was not at that time not knowing a lot about prostate cancer and how easily treated it is if caught early. I already had my plot picked out. It was yeah.
You're laughing. I'm not laughing.
Well, I was. I'm laughing.
I'm looking at you like
I'm laughing
wow.
now. I know a lot more now. But back then it was. I thought for this was it. Of course I became a fighter. I became a fighter. I wanted to learn. I started educating myself about the disease, and I did a lot of things which I had since learned don't do. Surf the web a lot, trying to get answers. A lot of misinformation. Everyone has an opinion. Ultimately, I took the advice of medical folks who kind of steered me straight. Ultimately, to being treated.
Okay. Did you? Not that it helped, but what did you do? Did you change your diet, or what did you do differently? Did you exercise?
The real story is, going back to that, what happened when I was given a diagnosis. I went through a very dark period. It took me a little while to kind of slap myself around to get to a place where I was able to think about diet and a lot of other things. That didn't actually happen until after seeing doctors. But I made a radical change.
Were you married?
Yep.
And did you tell your wife immediately, or?
Immediately. It was, I was always open about those things. I'm the kind of person who goes to see a doctor once a year, regular physicals and, checkups. Immediately, if there's something wrong, I go to see a doctor. Mm-hmm. So yes, there was a discussion about it, and that helped get through that dark period.
So did you go initially just to get a general checkup, or you?
No, I went because I had symptoms. Okay. There was something that was wrong.
Okay.
Yeah, and there were the erectile dysfunction issues and also urinary issues. I was actually watching television, and a commercial came on for I think it was BPH, enlarged prostate, and a medication that takes care of it, helps shrink the prostate and get you back to. And like a lot of those commercials, they list symptoms. And as the symptoms were scrolling down the screen, that's me, and I need to call my doctor tomorrow.
Okay.
Yeah, I thought it was going to be as simple as taking a couple pills and I'd be good to go. That wasn't the case at all.
So do women or wives, girlfriends, do they leave once? Because you talk to men, do they leave once?
I have, being honest, I have. There have been times when folks have their relationships have ended because of issues in the bedroom. But I like to think that the relationship wasn't strong to begin with. Mm-hmm. If and that's why I talk to men about prostate-related issues, as far as getting an exam, just to get checked out, and how important that is. That your life is so much more important than than your perception of what manhood is.
Mm-hmm. Right.
What you can do in the bedroom. So if it's something that can be treated, we have, at least at Roswell anyway, we have ways to help you get through the urinary issues and also the erectile dysfunction issues if it's a surgery you need or any type of treatment.
But at least that's a very good reason to go get checked early, because it can be cured.
Well, here's the thing. The thing that
treated at least.
But the thing I found is that men don't. Mm-hmm. And it's definitely a lot of what we do or about doing with Man Up is to do more outreach to women because women get men to do everything. Mm-hmm. And the gentleman who will show up for our event coming up on September 26th, the Cruisin for a Cure event, it's a car show and a free prostate screening event. A lot of those men are accompanied by women. It's an opportunity to be screened for free, and they attend.
Cruisin for a Cure, that event is coming up. Tell me more about that.
This is our 5th year. It is a car show which attracts men, families as well. We try to have activities for kids. Of course, there are cars. There's food. This year we're planning on having several food trucks show up for food. And it's also an opportunity to get screened, a free screening of PSA and DRE, a digital rectal exam, and also the blood test.
Okay, great. Now you're a cancer survivor. Is everything done? Is it in remission? Or
I am. I would say it is done. I've had no recurrence, and I'm almost at the point where Roswell says goodbye to me as a patient.
That's great.
Yeah. But I've not had any issues, and the treatment was a robotic surgery, and the first year was a challenge to my body. I call it coming back online.
Now, robotic surgery, you had your prostate removed? I
had it removed, yeah.
Okay. So how does that affect you moving forward? Are you able to urinate the same? Or?
I have no problem. Matter of fact, as Dr. Moeller mentioned, it's almost as if I didn't have surgery.
So sexual function is the same?
Restored, yeah.
Really? Because I thought that the prostate, you had to have your prostate to have an erection. That's not true?
Not true.
He's shaking his head no. So, guys, that's not the case.
The nerves go next to the prostate and can be left behind when the prostate is removed.
Yeah. As a matter of fact, I've had an opportunity to actually see a surgery, and you can actually see the surgeon peeling the nerves that encompass the prostate, peeling them away to spare them. So it's actually really fascinating, and the robotic surgery allows for that precision, precise movements like that. So it's a wonderful thing that they call it the Da Vinci robot, and it's a wonderful thing.
Richard or Dr. Moeller, what should a guy do who's listening right now, who's 40 or older?
As I've been saying for the past couple of years, at least associated with Cruisin for a Cure, and a lot of the listeners probably drive very nice cars. Okay, summer's out, you're out waxing your car, taking care of it, making it look good. If you can spend that much time taking care of your car, get to the doctor and have that much time spent on yourself. Go see a doctor. And also, if you're curious about the Cruisin for a Cure event, 1-877-ASK-RPCI, and you can register for the event and also pre-screen to be seen the day of the event to have your prostate checked.
And that's free. It's free screening?
Totally free. The car event itself is also free. If you bring a car, we're going to charge you for that. But the event itself is free for families.
And what's the date again?
September 26th, 9 to 4 p.m.
Okay,
that's a Saturday. No excuse for not showing up.
And I just got to say, that is absolutely 1,000% correct. You really don't have any excuse for not showing up based on what we just heard. Some phenomenal information from Dr. Moeller and Richard Satterwhite. We appreciate everything that you've shared with us this morning. Once again, Cruisin for a Cure is Saturday, September 26th from 11 a.m. to 2 p.m. at Roswell Park Cancer Institute, along with Men Allied for the Need to Understand Prostate Cancer, which is Man Up. And you can pre-register by calling this number, 877-ASK-RPCI, free prostate screenings. And again, based on the information we just heard, there really is no reason for you not to show up or call that number and pre-register for this event, Cruisin for a Cure. Once again, Saturday, September 26th, 11 a.m. to 2 p.m., free prostate screenings. There will be food there. There's a car show. You can see all kind of cars. I've been to the event before, and I've had the prostate screening done. It's very simple, very easy, goes very quickly, and you see some great cars. It's a really great event for guys. Again, 877-ASK-RPCI. I urge you to call that number and get pre-registered so you can get your free prostate screening. It is very important. Ladies, if you're listening and you have a guy, just make him do it. Thanks for listening to Issues and Views.
The views, opinions, and comments expressed on the program are those of the participants and not necessarily of this station.